Okay. I'm going to talk on are all Noacs the same? Now, essentially, as we know, there is more than a decade that we have been using Noacs, and there were a lot of confusion. With the first Noac to come was dabigatran, and followed by rivaroxaban, followed by apixaban. And we always have a confusion which Noac, when, which is superior in this scenario, what are the limitations of one versus another. I'm trying to go through the literature over a period of last 1 decade. We have come to some definitive conclusions, and I'll try to just go through that. Now, essentially, as you know, the prime indication where the Noacs came into role was prevention of stroke in atrial fibrillation, what is known as SPAF. And this stroke prevention, if you go back to the literature, the initial data is where that in a patient of atrial fibrillation, compared to placebo, aspirin will reduce the stroke by a relative risk of 22%. Then we showed that vitamin K antagonist was much, much more superior to aspirin, and the stroke risk could go down by 38%. And then we had data of comparison of Noacs versus VKA, where Noacs were still more superior by approximately a figure of 19% relative risk reduction. Thereby, we came to a definitive conclusion that either vitamin K antagonist or Noacs would be much, much superior to aspirin. And for all practical purpose, we should know that in a given patient of atrial fibrillation, for prevention of stroke, by and large, aspirin has no role unless the patient is extremely low risk, where there is no need to take a risk of giving VKA or Noacs, and where aspirin may be given, and it's a very minimal benefit. So basically, important to remember that antiplatelet monotherapy is generally not recommended for stroke fibrillation. We have certain facts, management considerations, atrial fibrillation, receiving warfarin. One important fact for us is that Asian patients were at 4 times the risk of intracranial hemorrhage compared to a Western counterpart. And therefore, the bleeding complication of intracranial hemorrhage was much, much more important to us compared to those people in the West. We also know that high TTR patients warfarin is an effective treatment for managing stroke in patients, but it was limited by its very narrow therapeutic index or window, as we would say. And patients within the TTR should be kept as high as 70% and closely monitored. If a patient TTR cannot be sustained about 70%, switching to a Noac should be considered. And we know being a very therapeutic window being very narrow, it's not very easy to maintain a TTR of above 70. Therefore, Noacs probably becomes by default treatment of choice, and more so in Asians where we are more concerned because the bleeding incidence is much higher, 4 times higher than the Western counterpart. As per the data from this Garfield atrial fibrillation registry, very recent registry, a patient receiving VK has spent majority of time outside of this. Therefore, again, by default, probably Noac. We have other limitations of warfarin. It is a long half-life, slow onset, slow offset, issues in perioperative breach anticoagulation, etc. Interaction with drugs and diet. And warfarin administration therefore requires frequent coagulation monitoring and frequent dose adjustments. And all these things collectively would tell us that because of high incidence of bleeding and difficulty in maintaining TTR, drug-drug interaction, drug-food interactions, etc., warfarin is by and large not the default therapy. And Noacs would probably become a default therapy in all these subsets of patients with atrial fibrillation to prevent stroke. Now, let us go through the evolution of Noacs. If we really go back to it, 1989 to 1993, there were 6 trials which compared warfarin with placebo and said that warfarin was far more better. Then the first to come in was dabigatran in 2009, followed by in 2010 we had the Rocket and the rivaroxaban versus warfarin trial trying to prove rivaroxaban is a good agent. This was dabigatran with warfarin. Then we had a trial of Noac versus aspirin, which was Everose, which was apixaban, and another trial, very important path-breaking trial of Aristotle Trial, which was again Noac versus warfarin in 2011. That is, if you see from 2009, every year there has been a trial of Noac comparison with warfarin or aspirin, and the last was the big Engage AFTV48 trial of edoxaban with warfarin. But mind you, edoxaban not being available earlier, you would not be interested in that data to a great degree. That means right from 2009, we have one after another huge mega trials, randomized controlled trials, comparison trying to show superiority or equivalence of Noac with univarfarin. What are the advantages which we are all aware? Just rapidly going over it, rapid onset of action, no significant food interaction, drug-drug interaction, no monitoring necessary. And established criteria for dose adjustment in elderly patient in case of renal impairments are now easily available to us, and thereby Noacs are much better off than warfarin. Look at the summary chart where we are trying to compare warfarin, dabigatran, rivaroxaban, apixaban. We intentionally not take endoxaban because it's not available over here. And if you really look at the mechanism of action, warfarin is inhibitor of vitamin K. Dabigatran is the only direct thrombin inhibitor, whereas rivaroxaban, apixaban, endoxaban are direct 10A inhibitor. This is 2A inhibitor, and this is vitamin K. Bioavailability, if you really look at it, is variable from a section like if you look at warfarin, it is 95% or more. Dabigatran is more protein-bounded availability, less rivaroxaban. Important to know that dabigatran is a pro-drug which has to be converted to active molecule in the body versus all other places. As far as food is concerned, this is important to know that food which are vitamin K, the high content vitamin K will interfere with warfarin action. And of all the Noacs, rivaroxaban, the action is best when taken with food, whereas dabigatran and apixaban has no interference with food and can be taken anytime. Important to remember, I repeat, rivaroxaban to be taken after food. And renal clearance, if you really look at it, 85% of the clearance in dabigatran is to kidney, and therefore, moment there is renal impairment, dabigatran would by and large be out. Opposed to that, rivaroxaban and apixaban are around 30% eliminated, and they both remain molecule of choice in patients with renal failure. We'll go through some other criteria down the line. And what you can see over here is warfarin is only 8% excreted by kidney, and therefore, good old days till now, we used to say that warfarin was the treatment of choice in renal failure, opposed to dabigatran, rivaroxaban, or apixaban. But now we have data that even Noacs like rivaroxaban and apixaban are maybe superior to warfarin because of some other additional characteristics which will come down the line. So in a sense, important point which I would like to draw from this slide is that rivaroxaban is to be given with food, one. And in renal patients, you can't use dabigatran, all other drugs can be used fairly. Let us just go through some of the trials and then the prime inference based on this trial. Apixaban, Aristotle Trial, 2011 is where it was there. And it was a randomized controlled trial development wherein patients with atrial fibrillation with atrial, one stroke risk factors, the Chadwell score being more than 1, were randomized to either apixaban 5 mg BD or warfarin. In patients who had 2 of the 3 characteristics fulfilled, either patient more than 80 years with weight less than 60 or creatinine more than 5. If 2 or more parameters were abnormal, then they were given a reduced dose of 2.5 mg BID Warfarin was always adjusted to maintain a target INR between 2 and 3. Primary efficacy point were strokes, and the safety point was major bleeding. And median age of the people were around 70. Mean change score was 2.1. ETR was 62%. And what they found was the primary efficacy point, the stroke incidence was lesser with apixaban. If you look at safety point, bleeding was also about 31% lesser in patient on Noacs. So Noacs were more efficacious and more safer compared to warfarin in this trial. And that is where it's supposed to be Dresen's birth. Dresen was a guy who published this article, and that changed the practice since 2000 based on this Aristotle trial. Notice this. Now let us look at Noacs versus warfarin. Various other Noacs, if you were to look at, and you are looking at the stroke and systemic. That means you're looking for the efficacy. Every time we are going to look at efficacy and safety. And you're looking at efficacy, anything which is to the left of this unity line is superior, and you could see dabigatran in both the doses, rivaroxaban, edoxaban, everything was superior or better than warfarin in prevention of stroke, except low dose edoxaban, which was not effective. So if you're looking at stroke prevention, edoxaban's low dose is not effective. Important to remember here. Dabigatran in the dose of 150 milligram BID was the best drug to prevent stroke and systemic embolism if you were to take the patient age group across. But mind you, when you bifurcated those in elderly versus less than 65 and above, dabigatran was good in patients who were younger in age because the bleeding complication was lesser there. But the moment you went to higher age group, this benefit was not there. So if you have a patient who is young and you want to prevent stroke, probably if we can tolerate, dabigatran was superior. Yes, rivaroxaban and apixaban are reasonably good, and edoxaban also. But the moment you cross elderly patients, this benefit is lost because they have higher bleeding tendencies, and that is where probably other drugs like apixaban or rivaroxaban will have an impact. Look at the safety factor, most important thing. All of them uniformly reduce incidence of intracranial hemorrhage. And this is one fundamental strong benefit of Noacs versus warfarin. Reduction in incidence of intracranial hemorrhage. And as I told you initially, Asians have 4 times higher chances of getting this. And therefore, beyond doubt, even if you have a choice of warfarin versus Noacs, in every single individual, unless there is a specific contraindication, warfarin would be preferable over, Noacs would be preferable over warfarin because of this one fundamental benefit of reduction in intracranial hemorrhage. Look at all-cause deaths. Again, all of them were reasonably good compared to warfarin. So they will all reduce all-cause deaths, they will reduce stroke incidence, and they will reduce intracranial hemorrhage. And therefore, Noacs are superior to warfarin for stroke prevention in atrial fibrillation, except I repeat, those are patients of severe mitral stenosis. That is where you cannot give Noacs, and warfarin will be still used to prevent embolism and stroke in this patient. Or patient with severe mitral stenosis is the most important. But mild mitral stenosis and other valvular disease, you can still use Noacs.
Last 2 sentences.
Pardon?
Last 2 or 3 sentences were not clear.
Okay. Now can you hear me clearly?
Now I can hear you better, yeah.
So whenever you are talking of the efficacy and safety,
Yeah.
all Noacs are superior to warfarin in prevention of stroke, reduction of death, and reduction in bleeding, and especially reduction in intracranial hemorrhage. Only place where you will still use warfarin and not Noac is critical severe mitral stenosis, where Noacs are not supposed to be good, and warfarin is still the treatment of choice to
Right.
prevent embolic episodes in a patient of rheumatic mitral stenosis, which is critical where the valve area is less than 1.1 square centimeter area.
Very nice.
Now, therefore, if I were to summarize, if you look at it now, in green, ICH, all Noacs reduce intracranial hemorrhage and they are better than warfarin. Death is reduced by apixaban. If you're looking at major bleed, GI bleed, etc., they are released with low dose of dabigatran of 110 milligram or apixaban. Rivaroxaban in the modular dose or dabigatran in high dose can cause increased GI bleed and therefore they do not report it. And if you're looking at stroke prevention, I told you dabigatran is the most ideal drug in younger age group below 65. We're talking of higher age group, probably apixaban will score over. Look at the regional variation in patient with atrial fibrillation. In the Aristotle trial, we had an Indian data of this paper, and then we found that what was the conclusion? Not going to this. The relative benefit of apixaban compared with warfarin were consistent across regions with an even greater treatment effect in the reduction of bleeding in patients from Asia Pacific. That means this is one drug which had Indian representation and has conclusively shown its effectiveness and significantly more reduction in intracranial hemorrhage. That means safety. That was about the trial. Do you have a real world experience about the same thing? And this is a huge data, what is known as Aristophans. It's a collective data. It is a real world experience. It's an observational study. People were in mediclaims, etc. But a huge 434 patients, of which 1 lakh were on apixaban, 1.5 lakh on rivaroxaban, 1,67,000 on warfarin, and dabigatran were analyzed. And what they had a specific way of matching the thing. Ideally, there was no head-to-head comparison. So we go by what is known as propensity score matching, which essentially, not going to the depth, reduces the possible diassociated with the confounding variables. And what did it show? It showed that the incidence rates and hazard ratio of stroke, major bleeding, apixaban, warfarin score. If you really look at it, all these things, that all favors apixaban. This was a comparison of apixaban versus warfarin propensity score. And what it showed is apixaban was associated with 36% relative risk reduction in stroke and systemic embolism, and 40% relative risk reduction in the safety outcome of major bleeding. In nutshell, apixaban is superior to warfarin in terms of efficacy and safety. Now, this is another comparison from the same data, Aristophans, but now the comparison dabigatran with apixaban. And what it showed is that apixaban was associated with 28% relative risk reduction in stroke and 22% reduction in major bleeding compared to dabigatran. Mind you, this is not head-to-head comparison. This is propensity score matched cohorts. Therefore, they are not absolutely comparable, but reasonably comparable. And it shows that apixaban was superior to dabigatran in terms of safety and efficacy. And then we have a data of rivaroxaban with apixaban, again showing that apixaban was associated with 20% relative risk reduction and 45% bleeding reduction. Meaning thereby, all first was with warfarin comparison, then with dabigatran, and then with rivaroxaban. And everywhere we have data to show that probably apixaban is good efficacy and extremely good safety. So having said this, so far what we have shown you trials randomized control trials. Then I showed you the data from a real world study, and everywhere we have shown that probably compared to warfarin, Noacs are superior. And among Noacs, in younger patients, if you are looking at efficacy, dabigatran is good. Otherwise, all age group, or especially with elderly age groups, apixaban will score over warfarin, apixaban will score over dabigatran, apixaban will score over rivaroxaban. How to manage Noacs in clinical practice for SPAP? We are essentially looking at these 4-5 subsets: elderly patients, renal compromised patients, high risk of GI bleeding, and diabetes mellitus. Now let us go one after another. Noacs in elderly patient, apixaban efficacy according to the age group. Now look here very clearly. We have 3 subsets of patients: below 65, between 65 and 75, and above 75. Efficacy wise, if you look at it, below 65, I see over here, warfarin is better than apixaban. Meaning thereby apixaban scores over warfarin in patients who are above 65, not below 65. And we also have data that compared to warfarin, dabigatran is better. Therefore, in patients who are younger in age, if you're looking at efficacy, probably dabigatran is best, warfarin second, and other drugs third, or maybe even rivaroxaban first. But look at bleeding, uniformly less with apixaban at all age groups. So bleeding wise, apixaban is good at all age groups, but prevention of stroke and embolism not so good below 65. Noacs versus warfarin in patient more than 75 years of age. Here you have got dabigatran 110, dabigatran 150, rivaroxaban and apixaban. Apixaban superior in prevention of stroke, major bleeding in intracranial hemorrhage, all 3. Rivaroxaban effective for stroke prevention and ICI, but major bleeding was still neutral. And if you look at dabigatran 110 here and dabigatran here. So basically, bleeding is definitely total incidences in dabigatran 150 and rivaroxaban is same and more or equal to warfarin, but with apixaban it is less. Opposed to that, ICH was less in all subset of patients. All what it means is that if you have a patient with increased bleeding tendency, which we had covered last time, if you have a patient with increased bleeding tendency, you will prefer apixaban. If your patient is not a question of bleeding with young, no bleeding tendencies, probably rivaroxaban, dabigatran, everything will be efficacious. If you're looking at prevention of stroke, dabigatran 150 below 65 would be preferred. Dabigatran 110 will be only useful with high bleeding risk, but stroke prevention will not, bleeding will reduce. Now this is apixaban efficacy and safety versus warfarin in patients who are above 80 years. And clearly you could see that with warfarin, the stroke incidence is more, bleeding is more, ICH is more. Or in short, apixaban is superior to warfarin in patients above 80 years of age in reduction of stroke, bleeding, and ICH. Now, if you look at all Noacs, this is a ranking, which is plot of intervention, referred plot of intervention safety, and what was there? Apixaban was ranked best in efficacy of drug, followed by rivaroxaban, apixaban, dabigatran, respectively. These are in elderly patient. Mind you, we are talking of elderly patient above 80. Safety-wise, again, apixaban was superior. And you could see over here, this is efficacy best with apixaban, safety also best with apixaban. And you have over here rivaroxaban, and then dabigatran. Elderly patients, the efficacy also goes down, the bleeding also goes up. So dabigatran, good, high dose, younger age. Apixaban, good, elderly for both. Intermediate with the rivaroxaban. And this is where it is. This is what is known as FORTA, fit for the age classification. Rivaroxaban falls as A. A is indispensable. That means the best. Rivaroxaban is beneficial. Dabigatran, questionable benefits. And D, warfarin to be avoided. These are all for elderly patients. I repeat, old age patient classification. So in short, in a patient with old age, apixaban is best. Rivaroxaban can be used if necessary. Dabigatran, we are not really sure whether it is useful. And warfarin should not be used. Having said that, in elderly patient, look at renal compromised patient. I told you in the initial pharmacodynamics that apixaban and rivaroxaban, 30% excretion to kidney can be used. Dabigatran, 85% excretion to kidney cannot be used with renal failure. Warfarin, very small, can be used. And this is what it is. Now important what you have to remember. In a patient of CKD, in general, the thrombosis and hemorrhage are much higher. If you can look at it, the annual stroke rate is shown in dark blue versus in patient with normal EGFR. The incidence of annual stroke is high, ischemic stroke is high, all-cause mortality is high, major bleeding is high. In short, CKD is extremely high risk for stroke, whether it is annual stroke, ischemic stroke, all-cause mortality, and major bleeding. Therefore, this subset, which is high risk, and when you have to really treat those subsets of patients, you have to know what you will have to do. Therefore, every single patient, ideally, whenever you start in a drug, at the end of couple of months, you need to recheck EGFR. And how much it is, whatever is the creatine clearance, divided by 10 is the time when you should recheck. So your creatine clearance is 60, then every 6 months you should check EGFR. If it is 70, every 7 months, if it is 30, every 3 months. And Noac in renal failure excretion, as I told you, Dabigatran excretion is maximum in kidney, and it goes down with rivaroxaban, and apixaban. This is what therefore becomes treatment of choice. And if you look at non-end stage renal failure, therefore, if you have a patient of CKD, all these various trials very clearly show that stroke incidence was least in Rely trial, the EGFR is about 30, whereas in Aristotle trial it could be used, and the bleeding was maximum with Aristotle was also less. Very clearly, Aristotle trial where apixaban was used, stroke incidence was low, major bleeding is less, mortality is less, and therefore becomes a treatment of choice if you're looking at the incidence in non-end stage renal failure. In Rocket trial, here it is shown the statistics are not available. Various other real-world trial and other data that show that it is also reasonably good and can be used, especially with low bleeding risk patients. High bleeding risk patient, rivaroxaban can cause bleeding, and therefore apixaban is very easy. This is what is the Indian Eliquis label. If they say mild, moderate, or severe renal failure, no death is required unless the patient fulfills criteria for dose reduction. But when you have the dose reduction, what you remember is 2 out of 3 criteria. Only high creatinine is not the criteria. High creatinine with low weight or high creatinine with old age. Both put together, 2 out of 3 criteria satisfy the dose should be reduced to 2.5 BID. And this is where it is. Dabigatran can be given in renal failure with only EGFR above 50. Whereas other drugs, as you could see over here, rivaroxaban can be given till 30, apixaban till EGFR of 50. And now we have data on dialysis also somewhere where again the apixaban can be given. The apixaban can be given across the spectrum in patients with renal failure. So therefore, we can say that apixaban can serve as a potential alternative to warfarin as an anticoagulation agent in patients with ESRD due to significantly lower risk of major bleeding. There is another issue with warfarin, and that is what is known as calcification of the vessels, which is an inherent problem with all vitamin K antagonists, and that can worsen the kidney problem and worsen the kidney failure. And therefore, probably nowadays, compared to univarfarin or warfarin or vitamin K antagonist, apixaban is preferred because warfarin can itself cause further worsening of renal failure by calcification of the renal vessels. Look in terms of high risk of GI bleeding. Now, when you are Noac related bleeding can be directly systemic anticoagulation effect, incomplete absorption and critical and direct cause effect, especially with dabigatran, there is tartaric acid which can cause this problem and inhibition of the mucosal healing. These are the various mechanisms which it can cause, and that the data very clearly shows the rate of major bleeding in the pivotal Noac trials adjusted to the warfarin increase the risk, and major GI bleeding, if you look at it, is much more warfarin. But what is important there was a little data differences in GI safety profile among our anticoagulants, and this data clearly showed that the risk of GI bleeding is significantly varies among the different Noac regimes, and evidence shows that apixaban and edoxaban had the most favorable bleeding safety profile, while rivaroxaban and dabigatran were the least safe of the drugs. That means whenever bleeding is an issue, probably apixaban would have an age, dabigatran and rivaroxaban would have a higher incidence. Therefore, the European Society of Cardiology guidelines, in patients with high risk of bleeding, Noac preparation should be preferred over dabigatran, pyridine, rivaroxaban. So basically, it should be apixaban, which should be useful in patients with this. So either you can give low dose dabigatran or apixaban whenever the GI bleeds the problem. This is what it's shown over here. Then in patients with history of who already has a history of bleeding, again there are data to show very clearly that the beneficial effect of apixaban or warfarin for stroke, hemorrhagic stroke, or bleeding remains consistent regardless of history of bleeding. That means even if the patient has a history of previous GI bleed, you want to reinstitute a therapy, apixaban is the treatment of choice. Like chronic renal failure, patients with diabetes also have a extremely high risk of stroke and bleeding compared to a non-diabetic patient. And therefore, diabetes and atrial fibrillation together forms a very high risk group for systemic embolism and ICH infected. Therefore, with these patients also, if you look at all these data, results I would just go through. In a total of 1,54,000 with apixaban and rivaroxaban were associated with lower risk of stroke and embolism. So prevention of stroke embolism, apixaban, rivaroxaban, and as I told you, younger patient probably rivaroxaban. Apixaban is associated with lower risk of bleeding, and compared to dabigatran and rivaroxaban, in a sense the same thing, same conclusion again. Apixaban efficacious, less GI bleeding. Rivaroxaban efficacious, but more GI bleeding. High risk of GI bleeding, avoid rivaroxaban or high dose of dabigatran. So if I were to now summarize all that we have said, randomized controlled trial data shows that apixaban 5 mg BID showed superior efficacy and safety at the same dose, and dabigatran 150 mg BID showed superior efficacy. Dabigatran 110 showed superior safety against warfarin. Rivaroxaban was non-inferior to warfarin and safety concern of GI bleeding. And individual population, elderly population, apixaban has a favorable safety profile. Apixaban is recommended first option in this population of elderly. Similarly, in renal failure, Noacs are better than warfarin. First choice is again apixaban. GI bleed, apixaban has shown numerically lower GI bleed. And consensus statement of 2017 by the experts show that apixaban is the first choice of drug for elderly and patients with high risk of bleed. Lastly, apixaban has considerable benefit with respect to lower GI bleeding in high risk subset. So I think I will stop over here and we'll open to further discussion.
Well done, Bhaskar.
Very well done.
You mentioned edoxaban.
Right.
Edoxaban, we've not heard much about edoxaban.
No, it is not available over here locally.
No, no, even if it's not available, what is any benefit or other Noacs?
It is equally safe for GI bleed. Low incidence of GI bleed and reasonably efficacious. So if you're a patient of high GI bleed, yes, but when you give a edoxaban again at a 2 dose, 60 and 30, 60 dose is good, efficacious, and low GI bleed. The lower dose is not efficacious, but still very, very low dose. So if you have a patient where you want to give extremely high risk, probably edoxaban would be the low dose. For transient people who had bled, GI bleed, and you want to reinstitute, probably that can be the first thing to be started, and then change your apixaban.
Sir, are the Noacs are superior to warfarin even in PE also? DVT cases also?
In which case?
DVT, prevention of pulmonary embolism. And
Yeah. Now, if you're looking at pulmonary embolism, probably we have a reasonably good data, but much more data with rivaroxaban compared to any other drug. I mean, for two other indications, that is peripheral vascular disease, coronary artery disease, and DVT, probably everywhere we have much more stronger data with rivaroxaban. This is all what I was telling you was for stroke prevention in atrial fibrillation. We have a trial where you have used rivaroxaban in the dose of 2.5 milligram BID along with aspirin 75 milligram in post-MI or post-ACI patient after 1 year, high risk, diabetic, etc., or associated multiple involvement. That means the patient has associated peripheral vascular disease and or stroke, multiple disorders. Probably the only data is available with rivaroxaban 2.5 milligram with echosprin 75. So that is as far as coronary artery disease is concerned. If you look in terms of peripheral vascular disease, again, we have data only from rivaroxaban, low dose for that. And if you look at DVT again, I think the best data is this. But again, if you're looking at very elderly patient where GI bleed is a problem, probably apixaban might have an aid. Or if you have a patient with impaired renal function, probably apixaban will have an aid. But probably if the eGFR is about 30, rivaroxaban will have. So whatever we discussed today was specifically for stroke prevention in atrial fibrillation. But other three subsets, peripheral vascular disease, cardiovascular disease, and DVT, probably rivaroxaban would be preferred option, except when eGFR is very low, below 30 or below 50, or very elderly patient with high bleeding risk.
Do you use vascular rivaroxaban 2.5 milligram twice a day along with aspirin?
In a patient who has a
in patients of chronic coronary heart disease being pushed so much.
We have been using only in patient who has associated peripheral vascular disease or a TI or a stroke and a coronary artery disease together. So we have multiple things, or patient has high recurrence. He had one stroke, say a coronary event, ACS now, despite adequate therapy, dual antiplatelet drug, proper beta blocker, statin, if he gets a recurrence within 6 months, then probably that subset, yes, not otherwise.
He is being pushed so much.
Yeah, I mean, not using as much they are advertising.
And the trial, tell me, Bhaskar.
The drug, this trial was a trial which was done many years back. Suddenly it got a push by the industry. And probably the real indications are only when you have multiple coronary event in a short time, or a patient with coronary event along with peripheral vascular disease and stroke, along
And
with
the trial also was Bhaskar
after
after 1 year after chronic coronary heart disease.
Yeah, after 1 year, we're talking of after 1 year.
And again, the risk of bleeding was quite high.
Bleeding is high. So basically, again, as I told you last time, what we took, I went through the details of all those various charts where I showed you about precise depth trial, ARC bleeding score. And only when you find that patient is low risk of bleeding, you can think of all these options. The moment you say high risk of bleeding, I showed you last time that after 1 month of the therapy, the risk of bleeding predominates and scores over the overall ischemic risk, and therefore bleeding risk has to be given much more importance after 1 month of acute coronary syndrome or even after 1 month of stenting. So key thing is bleeding risk. If only when you find low bleeding risk and all these options are open. Otherwise, you should not embark on it at all.
Sir, is there any data of Noac use in portal vein thrombosis? Portal vein thrombosis plan?
Yes. There are data of use in portal vein thrombosis. And I have 2 patients who are on that, who have responded well to it. There are now data on portal vein thrombosis, where there are data on apical thrombus in the LV plot. So far, if you go by literature and trials, there are only trials of warfarin for LV apical clot, left ventricular apical clot. But now there are scarce data available of Noacs in this subset with reasonable, but they are all scared anecdotal cases rather than huge data. But if you are really worried, elderly, bleeding is a concern, maybe.
But in portal vein thrombosis, Bhaskar, risk of bleeding must be high, is it not?
Agreed. So that is where Noacs are superior. You have to titrate the dose. They find a lot of difficulty. But we have one very close relation of mine, another who's had a hepatitis B virus, cleared fully with interferon 2 courses fully. And later on again went into something like ascites. On investigation found to have portal vein thrombosis and severe portal hypertension, some varices. And this patient, they kept on Noacs, repeat check, that is, the whole vein has opened up well. So they are using it. Now, how much data I'm not sure. I'm just telling based on these 2 patients of mine, where the hepatologist have started this therapy, and both of them have a good response in terms of total dissolution of clot and recanalization.
Is it rivaroxaban in that condition, sir?
They were on Xarelto, yes. They were on Xarelto. And they both these cases with Dr. Samir Shah at Global Hospital. So they might be more aware of the data. I'm not sure, but at least these 2 cases which I was involved, I'm aware that they are using.
How frequently do we see cases of hepatic cirrhosis, social obesity?
And so basically, we now see that because our center at Jupiter does about 75 to 100 transplants. So it's a very huge liver center, and therefore we have a lot of patients coming in and out, and these people might be identifying that. Like if you're in routine practice, probably you may not see even 1 case of portal vein thrombosis post-clearance of hepatitis. But Jupiter being and Global, all they being a center of excellence for hepatic transplant now, probably all types of cases come over there for references, and that is where we have seen. So probably it will be a totally different subset of patient we are talking of. In a routine clinical practice, probably will not see.
You don't have routine practice, Bhaskar. How frequent have you seen cases of hepatic cirrhosis?
Cirrhosis we see, sir. Nowadays, a lot of
Such
cirrhosis
cases.
we are seeing
Patients with
for the fatty
obesity.
infiltration of liver, and non-alcoholic fatty stage is leading to this. We are seeing it, sir.
You're seeing it.
We have 2 or 3 Jain saints right now. I saw both cirrhotic and ascites. Definitely total abstinence from alcohol. Never there. We have seen it, but not very common. But we are seeing it. Again, as I told you, we probably, unfortunately, or fortunately, working in a center with a huge liver transplant program going on. We see that, and our transplant program, the last 100 transplants which we did, about 53 or 54 were non-alcoholic hepatic fatty liver going into cirrhosis. So probably equal, 50% were alcoholic, 50% are non-alcoholic.
Right.
LV apical clot we see frequently, and we have now taken liberty of starting Noacs in this subset of patients with good result. But if you ask me a concrete proof to start that thing, we don't have any concrete proof for that. any data that whether you can really start, if you really go back to literature, if you go back to textbook, they would still say use univarfarin in MVFI. Epla syndrome is another subset where warfarin has to be used. And small subset of patients in some malignancies, they again still prefer warfarin. So these are three subsets: warfarin, Epla syndrome, and severe mitral stenosis. That probably still warfarin might have an edge over Noacs. Otherwise, in all other subsets, probably Noacs are good.
Good. Nice.
Good review and good discussions.
So what is there next week, Sandeep?
Next week, let me see. Samir is planning to review on sudden cardiac death.
Okay, good.
Yeah. So he should be talking on SCD.
But he's not being seen now in our meetings.
He will be seen. In fact, he is doing the pacemaker now.
Someone should speak on Ukraine fight.
Terrible.
Fight.
Very.
Bhaskar, so what was your last discussion with Putin?
Putin, yeah, he said Putin, you say you put out. Like that.
Very aggressive.
Everyone.
Very aggressive. He's not bothered about the rest of the world.
He's not aggressive. He's he's a personality disorder. I mean, they say that Russians and Chinese, these two subsets of people are, you can never rely on, you can never trust any one of them. As they used to say that even in Russians about some 30, 40, maybe longer time, I think some 40, 50 years back, a student's batch went to USA and they went around and saw some US, they meet the US envoy and ambassadors and everything. And they gifted him something, some ball, some good photographs which can be kept on the wall and all of that. And then later on they realized that they put cameras inside and looked at the sensors and which were giving information to the Russians all throughout. For 20 years, they never realized that all Russian information, I mean, American information was getting passed to Russians through that photograph frames, which the young students of 20, 18-year-old had given and gifted.
Oh my. See, the number of Indians are going to Ukraine for studies. Is it not terrible?
Yeah, yes, terrible. These guys went up.
They will become. And they will come and practice here.
Most self-centered countries are Russia and China. They would care a hang about what will happen to other people. Their inner tendency is genocide. Remove the whole gene, the entire genocide. So, anyway, I think they have their goals in mind. Putin is playing every one step after another step, very calculated move, very intelligent person, but unfortunately self-centered, not worried about the consequences.
Hey, whatever embargo these people are putting, China will supply.
Everyone is self-centered. Right now, China and Russia together. Down the line, sometime they will again have a separate goals and their approach will totally change. Because the दुश्मन का दुश्मन दोस्त ऐसा है.
Okay, good.
और क्या?
Putin's lookalike is Nasir Hussain. It was shown on the TV.
Yeah.
The famous commentator Nasir Hussain and great cricket.
He was a captain. He was a captain of the English cricket team.
Good cricketer, but also good commentator. Yeah.
Commentator, yeah. Commentator later. First he was captain of the team.
Yeah.
English team.
That's right. Anyway, nice discussion today, and nice discussion on Putin also. Thank you.
Yeah, now Putin has put out everyone in the world.
Chalo, bye.
Bye.
Bye-bye. Bye-bye.
Bye, bye, bye.
Host to close. Host
Great
to close first.
soon.
किधर है? Leave किधर है? Leave. Leave.
Oh, Sanjay Vaidya.
You'll need to unlock your phone first. Which phone number for San?
Oh, Sanjay Vaidya.
Which phone number for Sanjay Vaidya? Something went wrong. Please try again.
Call Sanjay Vaidya.
Which phone number for Sanjay Vaidya? Calling now.
वह अस्थायी रूप से सेवा में नहीं है। कृपया कुछ समय पश्चात प्रयास करें। Is temporarily out of service. Please try later.
Very challenging.